Today's show is sponsored by strawberry.me. As nurses and future nurses, so much of what we do revolves around solving problems. So that when it comes time to focus that attention on ourselves, it can sometimes feel overwhelming. I've recently felt so overcommitted and like my days just spiral out of control. So I decided to try something new. I decided to try personal coaching with strawberry.me. It has been so incredibly eye-opening. My coach Anne asks me such great questions and helps me focus on what really matters. She's not telling me what I should do. She's helping me discover what is going to help me reach my goals. With Anne's help, I've set up consistent routines and daily habits that have made a huge difference in my overall well-being and help me feel like I'm finally back in control of my days. With strawberry.me, you're connected with a coach who's perfect for you, often in as little as 4 hours. And I love that Anne checks in with me periodically to see how I'm doing. It's a great motivator and reminder of the goals I've worked toward. Visit strawberry.me/nursemo. That's strawberry.me/nursemo and take charge of your future with the help of a certified coach. And get a $50 credit when you sign up at strawberry.me/nursemo.
At Sierra, discover great deals on top brand workout gear, like high-quality bikes, which might lead to another discovery. Getting back on the saddle isn't always comfortable. Good news is Sierra has massage guns. And chafe wipes, too. Discover top brands at unexpectedly low prices. Sierra, let's get moving.
Hi there, I'm Nurse Mo, and this is the Straight A Nursing Podcast, where I teach nursing concepts and share tips to help you thrive in nursing school and beyond that at the bedside. Today, we are going back to basics to review a fundamental concept that is probably the one I use the most when I'm standing at the bedside of a patient. And that, my friend, is the concept of all the things that come into play to regulate blood pressure and what is going to happen with the patient in regards to different body systems when blood pressure is low. First, let's take a quick minute for our listener shout out, which goes out to Mia, who says, "Hi, Nurse Mo. I just wanted to reach out and tell you how much your podcast has helped me in nursing school. Last semester, I was on the verge of failing med-surg when I stumbled across your podcast, looking for anything to help me. After I started listening to it while I drove, cooked, and cleaned, my grades improved so much. I ended up passing and have been using your podcast this semester in my peds and OB classes. You are such an amazing resource that I share with every lower level nursing student I am friends with. Thank you so much for all you do." Mia, thank you so much for reaching out to share your turnaround in nursing school to go from almost failing to passing your classes. That is absolutely amazing, and I'm so very proud of you. All right, are we ready to jump into the factors that come into play to regulate blood pressure? So when you are assessing your patient, there are all kinds of things you're going to be looking at to determine if this patient is stable or not stable. And one of the most important data points you are looking at is blood pressure. What is blood pressure? How does it play into your patient's overall picture? And what factors cause it to go up or, in most cases, more importantly, go down? So that's what we're talking about today. So first, let's talk about what exactly is blood pressure. So blood pressure is a measurement of the amount of force that the blood exerts on the vessel wall. Now, this force is a product of the amount of volume in that vessel, the size of the vessel, and the resistance to blood flow that is present in the vessel. And the two big determinants of blood pressure are cardiac output and total peripheral resistance. So now let's talk about cardiac output. Now, if you think back to your physiology class, You may recall that cardiac output is a component of stroke volume and heart rate. So cardiac output equals heart rate times stroke volume. So what is stroke volume? Stroke volume is determined by preload, afterload, and the contractility of the heart itself. So again, stroke volume is determined by preload, afterload, and the contractility of that heart muscle. So we'll talk about each of these components. Preload is the amount of stretch that is placed on the cardiac muscle fibers at the end of diastole. This stretch is caused by the amount of blood volume that is present. More volume, meaning more blood in the heart, means more stretch. More stretch leads to higher contractility and higher cardiac output. Now, think about it like this. I like to think about it like a rubber band. Like if let's say you have a little brother and he's annoying and you want to get back at him because he's always bugging you, you might take a rubber band and flick it at him, right? So let's say he's across the room. So you've got that rubber band. If you want that rubber band to fly all the way across the room, what do you need to do? You need to pull back on it pretty far, right? You need to create more stretch. And when you create more stretch on that rubber band, when you let it go, what happens? It contracts quickly and it flies across the room and it hits your little brother right in the middle of his shoulder or something. So that's what we are looking at when we're looking at stretch in the heart muscle. So more volume is going to cause more stretch on those fibers, and then that's going to cause greater contractility and higher cardiac output. Now, note that the opposite is also true. Less stretch leads to less contractility and lower cardiac output. So when you're looking at the heart, you'd have less stretch if there was less volume in there, right? So if the patient is very fluid volume deficient, you're going to have less stretch. And then cardiac output would be lower as well. So that's preload. Next is afterload. Afterload refers to all those things that oppose the ventricle's ability to eject and empty during that contraction phase. In other words, it's the force the ventricles have to work against in order to eject blood as the heart contracts. Now, the big things that come into play here are the valves, so the pulmonic valve and the aortic valve, blood volume, blood viscosity, the elasticity of the pulmonary artery and the aorta, and something called meta-arterial vasoactivity. Now, that is a really big term that simply refers to the ability of those short vessels that link arterioles and capillaries, those are the meta-arterioles, the ability of those to dilate and constrict. So again, the big things that come into play with afterload are the valves. So the valves we're most interested in are, of course, going to be the pulmonic and the aortic valves, the amount of blood volume, the viscosity of the blood, because thicker blood is harder to move around, the elasticity of the pulmonary artery and the aorta, and that meta-arterial vasoactivity, which is the ability of those meta-arterioles to dilate and constrict. So that's afterload. And then contractility is the heart muscle's ability to shorten the fibers, which create tension. It's essentially the contractile force. So you can see how all of these things kind of relate together to determine stroke volume. And then that other component of cardiac output was also heart rate. Heart rate can be too fast, it can be too slow, or it could be in that Goldilocks zone. It can be just right. So earlier I mentioned that the two big determinants of blood pressure are cardiac output and total peripheral resistance. Now, we just went over cardiac output. Now let's talk about total peripheral resistance. And this is determined by a few things. One of those is the length of the vascular bed. Another is the viscosity of the blood. And a third is vascular tone. So we have length of the vascular bed, the viscosity of the blood, and the vascular tone. Now, looking at those three things, which one to you seems like it could be more variable and adjustable in a moment-to-moment situation? So if you said vascular tone, ding, 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 you are absolutely right. It is the most variable. Now, when we see this come into play is when the arterioles constrict and dilate. So when they dilate, what do you think happens to total peripheral resistance? Is it going to go up or is it going to go down? So when they dilate, TPR goes down. There's less resistance. And when they constrict, the opposite happens. TPR goes up. Think about it like a garden hose. When you take your garden hose, you turn it on and you partially occlude the spout with your thumb, what happens? You're constricting the opening. Basically, you're making it more constricted like a vessel would be, and TPR goes up. That water shoots out really fast, right? So think about vascular tone in that way. And then just one other thing I want to mention here. Now, length of the vascular bed, that's not really going to be variable. It's not like you're going to grow more vessels or have less vessels, but viscosity can change, though it's not going to change very quickly. When you think about viscosity, think about someone with polycythemia vera who has a lot of red blood cells, or somebody with really high blood sugar. That blood is going to be thick, it's going to be more viscous, which can cause an increase in TPR. Now, we can give fluids to dilute the viscosity of the blood, which can help, but that's more not as variable as the vascular tone, which kind of happens in the body. In most cases, when things are working well, happens on its own. So one of the key concepts that you learned in your physiology class is that the body is always trying to achieve and maintain hemostasis, until it can't anymore, right? And then that's when a patient is going to be really, really sick. So there are a lot of different mechanisms that come into play when regulating blood pressure. We have chemoreceptors, baroreceptors, the sympathetic nervous system, and the endocrine system. So let's talk a little bit about each of these. First, we'll start with chemoreceptors. Now, these are located in the carotid sinus and the aortic arch. And what they do is they sense increased carbon dioxide, increased hydrogen ions, and decreased oxygen. All of these things are going to trigger the sympathetic nervous system to increase blood pressure. And then we have baroreceptors. When you think about the word baro or the prefix baro, think about pressure. So these baroreceptors are located in the carotid sinus and the aortic arch, and they sense changes in mean arterial pressure. And they send messages to the brain. And when mean arterial pressure is high, these baroreceptors are going to send more and more signals so that the sympathetic nervous system is suppressed and the parasympathetic nervous system is enhanced to cause lower blood pressure and lower heart rate. In other words, those baroreceptors tell the sympathetic nervous system to back off and tells the parasympathetic nervous system to come on in and step on the brakes, because that's what the parasympathetic nervous system does, right? So when MAP is low and these baroreceptors are triggered less, what do you think that does? It's going to send a signal to the sympathetic nervous system to say, hey, blood pressure is low. Get in here, do your thing. Let's get blood pressure up right away. So looking at what the sympathetic nervous system does to help blood pressure is it's going to cause vasoconstriction. It's going to cause faster respiratory rate as well. It's going to cause a faster heart rate. It's going to cause increased contractility. All of these things are going to play a role in increasing blood pressure. And then I mentioned the endocrine system. The endocrine system sends chemical messengers, which are basically hormones, that affect the diameter of the arterioles, causing them to dilate or constrict. Remember that garden hose? That's what the endocrine system is going to do. It's going to basically make your garden hose bigger in diameter or smaller in diameter, and this drastically affects blood pressure. So hormones that increase blood pressure are things like vasopressin, angiotensin II, and some prostaglandins. Other hormones that come into play are antidiuretic hormone and aldosterone, which work to maintain fluid balance, which helps maintain optimal blood pressure levels. And then hormones that decrease blood pressure are going to be nitric oxide, histamine, and some other prostaglandins. So before we move on and talk about how you will use this information to assess your patients and understand their risk for experiencing hypotension, which in the clinical setting, we do get concerned when hypertension is really high and causing organ damage. Most of the time, though, your issues with blood pressure being in the danger zone are going to be when blood pressure is too low. So let's take a quick break, and then when we come back, we'll talk about some common causes of hypotension so that you can get a really good understanding of when you're assessing your patients to understand what's going on with them and how that can relate to possible hypotension. When it comes to grocery shopping and meal planning, I've got a bit of a problem. It's time. Time is the problem. And when I don't take the time to plan ahead or go to the store, guess what happens? Cue the takeout. But Hungry Root has changed all that. It really is the easiest way to eat healthy. Hungry Root is like having my own personal shopper and nutritionist all in one. They make recommendations based on my preferences and my health goals, and all I do is go online, click, 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 and like magic, my groceries show up complete with recipes that can be made in 15 minutes or less. They also have other healthy options like smoothies, snacks, ready-to-eat meals, and my favorite, the salad kits. I made a goal of eating more salad this year, and Hungry Root has made it so easy. You're going to love Hungry Root as much as I do. Take advantage of this exclusive offer. For a limited time, get 40% off your first box, plus get a free item in every box for life. Go to hungryroot.com/nursemo and use code nursemo. That's hungryroot.com/nursemo, code nursemo to get 40% off your first box and a free item of your choice for life. hungryroot.com/nursemo, code nursemo. So one of the most common scenarios that you will see is bradycardia. Now remember, cardiac output is a component of two key things: stroke volume and, what was the other one? Heart rate. So when the heart rate is too slow, or bradycardia, this can often cause the patient to have low blood pressure. So when that blood pressure cannot be maintained at safe levels, and you'll see this parameter often as systolic blood pressure, above 90 is the goal. You'll often see the MAP as well. So it's kind of interchangeable. In the critical care area, we tend to talk more about MAP. And on the regular nursing floors, we tend to talk more about the systolic pressure, but know that you could see both. So systolic above 90 is generally considered A-OK, and then a MAP above 60 or 65. And when we are not able to maintain that, then we start to think that this patient is being unstable. Now, note that bradycardia does not always mean your patient's going to have hypotension and be unstable. Bradycardia can be completely asymptomatic. I've taken care of many, many patients with low heart rates. I took care of a patient not too long ago. It was scary. I'm not going to lie. It was a little unsettling for me. But I had a patient with a heart rate in the high 30s to low 40s. It would come up into the low 50s once in a while, but for the most part, just chilling, hanging out, feeling fine with a heart rate that low. I think this particular patient did get highly encouraged to see a cardiologist because generally those heart rates are going to be really, really, really low. But you could have, lots of patients with bradycardia in the high 40s and the 50s who are just super, super great athletes, and they just have really strong hearts that don't have to beat as often. And they have asymptomatic bradycardia. Lots of patients will have bradycardia when they're sleeping, and their blood pressure is fine. So before you get too freaked out when your patient's heart rate is below 60, which remember the normal range is 60 to 100, you have to look and see if they are symptomatic. And one of the symptoms that can occur is a low blood pressure. But what if you've got a patient who's not an athlete or whose heart might be a little bit sick or who's just maybe recovering from an illness and they've got bradycardia? If that patient is also hypotensive, you have got problems here and we need to work on those. So the thing that you're going to do about it is, a lot of times you'll see that the treatment for low blood pressure is to give some fluids. Well, in this case, does the patient need fluids or do they just need an increased heart rate? So a lot of times what we will do is we will give the patient a medication to increase their heart rate, which then takes care of the bradycardia because again, cardiac output is a component of stroke volume and heart rate. Okay, so here's another one. What about the opposite, tachycardia? When the heart is beating too fast, ventricular filling time goes down. And what do you think happens to preload when the ventricles aren't able to fill completely? If you said, I think preload would be decreased and there would be less stretch and there would be less cardiac output, you are absolutely right. So when heart rate is too fast, and I'm not saying a heart rate of 110 is necessarily going to make this happen, but let's say the heart rate is 180. Oh my gosh, your patient could very quickly decompensate. And of course, this is a generalization. Just know that if your patient has tachycardia, you definitely want to be checking their blood pressure. And then there's atrial fibrillation or atrial flutter. So in these conditions, the atria are not contracting properly. And what happens here is they don't give the little squeeze that would push as much blood as possible into the ventricle. We call that little squeeze atrial kick. And the loss of this atrial kick that occurs in AFib and aflutter can reduce cardiac output by about 20%. So if your patient suddenly goes into AFib or aflutter, one of the first things I want you to do is see if they are having symptoms. Are they lightheaded? Are they short of breath? Are they having any chest pain? And hey, what's their blood pressure? If their blood pressure has been borderline and now they're in this weird rhythm, you're definitely going to be, well, I'll say most likely, but I'm leaning towards definitely going to be dealing with some hypotension issues. And then cardiac dysrhythmias. If your patient's having any kind of cardiac dysrhythmia, you need to check to see if it is affecting their blood pressure. Same with your patient who has heart failure. If that heart pump is not working well, do you think cardiac output is optimal? Probably not. So make sure you're checking blood pressures on your heart failure patients. And then what about shock? Now, I talk a lot about shock in other episodes, but if you just the overall big picture is if your patient is in a shock state, blood pressure is gonna be low. So, I'm talking about things like septic shock, anaphylactic shock. So you want to make sure that if your patient is having some kind of shock state, blood pressure is going to be a big, big concern for you. If you do want to dive into distributive shock, I did a fabulous overview episode. It's number 346. So if you want to dive into that, go and check that one out. Okay, another thing that's really common is volume depletion. Your dehydrated patient or your patient who has lost a lot of blood is going to try to compensate for that decreased volume by increasing the heart rate. So your patient suddenly, let's say your patient just had surgery, like a big belly surgery or something, and they're hanging out. Maybe they're having some pain that seems out of context or out of alignment with the amount of pain medication they've been having, and suddenly the heart rate skyrockets. I'm going to be super, super, super concerned that they're bleeding internally. A very common scenario you will see with your dehydrated patients is hypotension, tachycardia. And something you want to be very aware of with some patients is that they're not going to be able to compensate well. So that tachycardia is a compensatory mechanism for that low volume state, right? Now, what if they're taking a beta blocker? Can their heart ramp up to compensate? Not going to happen. They're on a medication to keep the heart rate lower. So in these patients, restoring volume is going to be the thing that helps them, okay? Giving them fluids, in some cases, giving them blood products is going to be just the thing that is needed. Well, and if they're bleeding, let's also stop the bleeding while we're at it. And taking care of those things, correcting that volume depletion, then blood pressure improves as well. Now, earlier you heard me mention hydrogen ions. And you might have been wondering, what does that have to do with any of this? Well, acidosis. Acidosis causes hypotension through some very, very complicated pathways. But that short version is that acidosis contributes to decreased cardiac contractility. It contributes to smooth muscle relaxation and increased nitric oxide production. And I already mentioned that nitric oxide is one of those things that also causes vasodilation, and that further drops blood pressure. So when your patient has too many hydrogen ions, they have acidosis, they're very, very likely to be hypotensive, and that hypotension can be profound. I saw this many, many times in my patients in the ICU who were very acidotic, and I knew I was going to be dealing with blood pressure issues while we worked to get their pH back in balance. Endocrine disorders can also cause low blood pressure when those hormones that help regulate blood pressure are affected. And then medications, another huge culprit. Medications that cause hypotension include diuretics like furosemide. Some antidepressants can cause hypotension. Levodopa, a medication utilized for patients with Parkinson's disease. Medications used to treat pulmonary hypertension or erectile dysfunction cause hypotension. And of course, medications that are used to treat high blood pressure can cause hypotension, especially if patients are taking too many. A lot of times patients will be on multiple medications for high blood pressure, and it can be difficult for some patients to keep track of all their different medications, so they could be taking too many. I was talking with a friend recently about an individual who had been taking hypertension medication and over time improved lifestyle choices, lost a lot of weight, got more active, was still taking the same dose of antihypertensive medications and having syncopal episodes. Very big chance there that that patient's blood pressure medication needs to be adjusted because some of the things that were contributing to their hypertension, like excess weight, have been reduced by all that weight loss. So basically taking too much or too high of a dose of hypertension medication definitely can cause some hypotension. So just to recap, some common causes for hypotension in the clinical setting, we have bradycardia and tachycardia, going into atrial fibrillation or atrial flutter, having a cardiac dysrhythmia, being in heart failure, going into some kind of a shock state like septic shock or anaphylactic shock, being volume depleted, whether it's from dehydration, maybe the patient's taking a diuretic and just urinating a lot and losing volume in that way, definitely can cause hypotension, or maybe they're bleeding. Acidosis can cause hypotension, endocrine disorders, and again, quite a few medications. So now let's talk very briefly about what happens when blood pressure is low. And the key thing we care about with blood pressure is organ perfusion, tissue perfusion. So, neuro, cardiac, lungs, kidneys, liver, all the body's tissues can be affected. Let's take a quick look at each of these to see what can happen with these key body systems. So, neuro-wise, low blood pressure can cause your patient to have decreased level of consciousness or feel dizzy when moving from a supine to a standing or sitting position. Remember that orthostatic hypotension? Yes. So looking at this, your patient is more somnolent, more tired, more lethargic. Check a blood pressure. Maybe their blood pressure is low. If they are complaining of dizziness, even just sitting in bed and they're complaining of dizziness, blood pressure, probably the first thing that I'm going to check. And what's happening here is low blood pressure is causing not enough blood flow to the brain, and very, very low blood pressure for a period of time can cause anoxic brain injury due to decreased oxygen delivery. So the consequences can be very devastating when that blood pressure is extremely low and very pronounced. So that's the brain. What about the heart? If the heart isn't getting enough oxygen, then some really bad things can happen. Cardiac arrest can happen. And probably, though, the most common thing that you'll see with low blood pressure, if it's symptomatic and causing cardiac symptoms, is some angina or some chest pain. That heart that is wanting more oxygen-rich blood is going to experience some pain. And if your patient says that they're having chest pain and they're hypotensive, you should be getting very, very concerned very, very quickly and doing something about this. All right, how about the lungs? In cases of blood loss, what do you think happens to oxygen carrying capacity in the whole body? It goes down, right? So in the lungs specifically, gas exchange is going to be affected. So the lungs aren't going to be able to function as well. And what you'll see is lower SpO2 if you're doing pulse oximetry, or if you do a blood gas, you'll see lower partial pressure of oxygen, or PaO2. And then with that, all those symptoms of hypoxia or hypoxemia of the patient who's having those lower oxygen levels. And then the kidneys. I will say that the kidneys really don't like hypotension at all. Well, probably no organ does, but you will see a lot of acute kidney injury. They're just so sensitive. Like, they get injured and they take it personally, and they're going to have this acute kidney injury for a while that patients have to then recover from. Hopefully, in some cases, acute kidney injury can become chronic renal failure. But just know you're heading into the clinical setting, you're going to see AKI, acute kidney injury, a lot. Many patients will go into this acute renal failure or acute kidney injury from even brief episodes of hypotension. So if you're seeing decreased urinary output in your patient, this is an indicator that those kidneys have not been getting enough perfusion. And in a lot of cases, this is due to fluid volume deficits, but it can also be due to that massive vasodilation in shock states. So watching renal output, urine output, really, really important, especially in a critical care setting. And then the liver, there is a condition known as ischemic hepatitis. You may also hear it called shock liver. And this occurs when the liver does not receive adequate blood flow. So if your patient is already sick, let's say they have sepsis or something like that, and they suddenly develop liver failure, then your patient likely has had a situation where the liver has not been getting adequate perfusion. They've gone into shock liver or ischemic hepatitis, and your sick patient just got incredibly sick, and things just got incredibly complicated very quickly. So lots of different body systems affected by low blood pressure. These are just some examples of what you might see in the clinical setting. And hopefully this helps you understand the complexities of blood pressure regulation and why it's so, so important to keep your patient's blood pressure optimized. Okay? So thank you so much for tuning in today. I hope that you are back here with me again very, very soon. And you may have noticed that we are doing quickie episodes on Mondays. So I will actually be in your ear much sooner than you are used to. So make sure you're following the show or subscribe to the show so that you do not ever miss a single episode. And if these episodes help you, I'd love if you would share them with a friend, a classmate, an instructor. Just get the word out there that this resource is available and a great way to review and study if you're a nursing student, maybe in your downtime while you're driving to clinical. And if you're a working nurse, I've got lots of goodies for you here too. I will see you again soon. Bye for now. This podcast is brought to you by Straight A Nursing, a proud member of the Airwave Media Network. For more educational podcasts, check out airwavemedia.com. And for more nursing-related content, go to straightanursingstudent.com.